several ambassadors who've joined us from foreign embassies. I see on my list here the embassies of Zimbabwe, Iran, Japan, Kuwait, who are all on, and I think there are a few others. I'm sorry if I have not yet managed to see your name on the list. But good evening. This is a very important webinar. The whole nation is seized with this, not just the whole nation, but the entire world is seized with the issues that we are all having to deal with. The challenges of the coronavirus, and of course for us in South Africa now, a new variant of the coronavirus. We know that we had gone through the entire period of the lockdowns and then the lifting of the lockdowns. We then had the development of the vaccines, and we all waited with bated breath for the vaccines to be developed. Fortunately, scientists across the world have managed to do this in record time, but you know, it's now being implemented on the go. So it's being tested whilst it is also being administered at the same time. And there are many things being discovered about the vaccines, as we discovered in South Africa, that the AstraZeneca vaccine has limited efficacy. Now, I told the doctors and the professors they mustn't use too much scientific language tonight, because they must speak in English, not in scientific English. So I shouldn't talk about efficacy and all of that, but I think what it means is that it's either effective or not effective. So we discovered that AstraZeneca, which we had bought, which was going to be administered to our health workers, and we certainly need to ensure that our health workers are protected. And I must take this opportunity to thank all of you who are here, health workers, really, because you are out there in the front line saving our lives. And I looked at the numbers last week of you know, how many prominent scientists, professors in medicine who passed on, about 20 in the country, and then medical doctors, about another 150 doctors, and nurses, about 100 nurses. And this was just the number that we know, you know, which is a huge loss for our country, because these are skilled people who have trained for a long time and were making a huge contribution, not just to saving lives, but to the science of what we are trying to deal with, the challenges. I was on a webinar the other day with mayors from across the world, and I think we have become somewhat of a little pariah country now, because people say South Africa has this variant, and you know, we're almost like lepers now. Nobody wants to touch us because we have a variant. And I was saying to the mayors that, you know, the fact that we actually found the variant is testimony to the really excellent scientists that we have in our country and the really good laboratories that we have. And I'm sure we are not the only country in the world. You know, my own kind of rudimentary knowledge of how viruses mutate means that, you know, people in other parts of the world might also have viruses that have mutated already, but they have not discovered it yet. And so, you know, the fact that we have this variant means that we also have really good science facilities and scientists in our country, and that is something that we should be proud of. So I think, you know, we must be out there telling people that, yes, we found it because we have good scientists and good labs, but maybe yourselves in other countries, you are still going to find out that you have some mutated variant of the virus. So the public has a lot of questions about the vaccine, particularly because now this problem that we had with AstraZeneca, I think we created this opportunity because we wanted people to ask the difficult questions, even the easy questions that they have, so that they can, you know, be more comfortable about, you know, whether this virus, the vaccine is going to work or not, whether they should take it. And given the fact that we have, I'm not sure whether it's 60 or 70% immunity in a country is required, we can't have 50% of our people afraid to take the vaccine because we won't reach that level of immunity. So I think a lot of education is required, and I'm glad the minister cleared up this morning. I know that Loazi was asking the questions to the minister that was coming across, and somebody asked about the minister to comment on the fact that people were saying it was a good thing that the Chief Justice Mokweng had indicated that the vaccine is the work of the devil, because the fact that the AstraZeneca did not work, maybe this is also indicating that he was correct. And the minister, I think, very nicely said that, well, the thing is, I'm sure that we have the same God. That's why we brought the Arch this evening. Archbishop is here with us, Thabo Makgoba. Arch, the minister said, he's sure that we all pray to one God, and that God loves everybody across the world. And there's no reason why God will allow the AstraZeneca vaccine to work for some people and not work only here in South Africa. So I think we don't have to be too afraid of the vaccines. So we have an amazing panel this evening of medical specialists who are both practitioners, policymakers, frontline workers, and I think they will give us different perspectives. So I want to start with, and I got to pronounce your name this evening, Dr. Aquina Tulare. Have I got it right, Dr. Tulare?
Not quite.
Okay, by the end of the evening, I promise by the end of the evening, if my phonetics are right, I will get it correct. But colleagues, Dr. Tulare, now let me be safer, is the head and advisor in the South African Department of Health. She has held the position of lead technical specialist and advisor, National Health Insurance in the South African National Department of Health since 2009. She sits on several boards, including the Health Professionals Council of South Africa and the Reserve Force Council. She has served for 10 years on the Medical and Dental Board of the Health Professionals Council of South Africa. So we have now a very learned, knowledgeable person. And Dr. Tulare, I think give us your perspective on where we are. People really just want to know, which vaccine are we going to get? When are we going to get the vaccine? Is it safe to take the vaccine? How long will the immunity last? Do we have to continue wearing masks? Do we have to continue social distancing, sanitizing? How long will we have to do all of this? So I think people just have these simple questions. They will put other questions later, but give us your perspective from the Department of Health, and you're an advisor to the minister, so would like to hear from you. You have the floor.
Thank you very much, Advocate, for that introduction. And good evening to fellow panelists and participants, and His Grace in particular, Archbishop Makgoba. Very privileged that we are sharing a platform with you. The questions that have been asked are quite diverse, and I'm going to try and respond to them in general so that I do not take time from my other fellow panelists to also make inputs. Where we are in terms of our management of the epidemic is that we have now gone through two phases of the epidemic. We had the first wave, which we picked on sometime in July, August, and the second wave, where we had our peak from October to just end of this January. And now we've just recovered from that. We have seen in the graphs that the numbers have gone down sharply. We had some interventions that were put in place to try and ensure that we observe, the non-pharmaceutical interventions of containing the virus and trying to flatten the curve. We know that we spent the festive season locked indoors, and Archbishop, we could not even go to Mass on Christmas Day because we had to try and keep ourselves. socially distanced. But as part of the plan to manage the pandemic in the country, we had several areas that we're looking at, starting with surveillance and monitoring the epidemiology, coming up with other measures such as testing, contact tracing, clinical management, research, coming up with other interventions that would be relevant, including on looking at vaccines as one of our options of ensuring that we manage this epidemic. And the purpose of looking at vaccines, because this is the purpose of today's discussion, is to ensure that we reduce mortality and morbidity in our population by achieving what is called herd immunity or population immunity. The department is advised by several committees that have been established to advise government on how to manage the epidemic. One of the committees that are, or two or three of the committees that I want to make reference to are Ministerial Advisory Committee on the COVID itself that has been with us through from the beginning of managing the epidemic. We established another advisory committee which was on social-behavioral change management, which includes the religious sector, traditional leaders, people in various leadership positions in society. We have included civil society in this committee as well to advise ourselves, to advise government, and to come up with proposals of how we could put in measures that would help us with non-pharmaceutical interventions on the epidemic. We have also established another committee that is called Ministerial Advisory Committee on Vaccines, which has come up with a lot of advice on how we should pursue the strategy for vaccination. One of the advices that came out of this committee is that for us to reduce mortality and morbidity and to achieve herd immunity, we need to look at vaccinating around 65% of the eligible population. And 65% of the eligible population, you must underline eligible, is around 40 million people. And I emphasize the eligible because from the advice that we have received, both from the MEC on vaccines, Ministerial Advisory Committee on Vaccines, and from our partnership with the WHO and other global players, is that at this point in time, we have to be a bit cautious around vaccinating children who are less than 18 years of age, especially because in some of the preliminary studies that have been conducted, we are not yet sure of the effect of vaccination on children. The other area that we are thinking about very carefully, and a minister made a reference to this morning when a question was posed, is on pregnant women and people who are expectant. That because we are not yet very, very sure of the effects on the unborn fetus, pregnant mothers have to seek advice from their practitioners, whether it's nurse practitioners or medical practitioners, to ensure that it is safe for them to be vaccinated and to look at other peripheral factors that must be taken into account if this advice is provided. So government, in line with the advice that it has received, had engaged in the process of looking at how we are going to procure vaccines for achieving this herd immunity that I have made reference to. And as far back as September 2020, we started engaging with some of the pharmaceutical companies that are manufacturing vaccines. And these companies, there's a long list of these companies. I will just give highlights. We started engaging with the Serum Institute, which is an institute that, with the COVAX facility, which is a facility that has been established in partnership with the WHO and other global players, but to support countries that especially are from the developing world, and even some of the countries in the developing world who felt that they needed the partnership and the solidarity that the COVAX facility was providing. We engaged with various manufacturers in terms of bilaterals, and these include companies such as AstraZeneca, which is it's currently under a lot of scrutiny and discussions. We discussed and had negotiations with companies such as Pfizer and Moderna and Johnson & Johnson. We have engaged with the African Union platform that has been established through the AU mechanism to look at our needs here in the African continent. We have also engaged with other role players who are in the manufacturing area, such as Sinopharm, Sinovac, which are from China. We have also engaged with the Russians through the Gamaleya Institute for their Sputnik V, and all sorts of other investors who are in this space to ensure that we look at what is available. Why we have engaged widely is because, as we are all aware, the vaccine is very, very scarce, and we have to use all our means to ensure that we get the vaccine that is going to enable us to vaccinate the 40 plus population that has million population that has been identified as being required for us to achieve herd immunity. The negotiations are very, very difficult. We have found that, in these negotiations, certain concepts emerge, such as vaccine protectionism, vaccine nationalism, where, nation states who have prepaid before we were able to have amassed, quantities of vaccines in terms of their orders, and smaller countries like ourselves are struggling to get this. So in line with this, because the negotiations are very, very difficult, a decision was taken, and looking at the global landscape, that government should be the one that is negotiating for the acquisition of the vaccine on behalf of the South African population. It would have been very difficult for smaller players to negotiate, especially because the conditions that were being set by some of the manufacturers could not be carried by small role players or provinces on their own. They required a national approach with national interventions put in place to ensure that we acquire the vaccine or the combination of vaccines. And what is also important is that as we are continuing with the negotiations, we found that there are certain preconditions that some of the manufacturers were putting on the table that we had to look at as a country and not just as individual players. And therefore, we are now at that stage where we have started looking individually at certain of the manufacturers and saying that this type of vaccine will be suitable for our context. All these discussions are taking place as South Africa is moving through what we call the resurgence or the second wave of the epidemic, and where we discovered that South Africa has now found that it has a variant of the COVID-19 virus that is unique to our context. It's called 501, and I think all of us have had engagements around this virus. It has created a lot of debates because with all the vaccines that are being developed, one has to make sure that our vaccination is going to respond to the new variant that is unique to our context. And recently, as far back as a week ago, we came to know that our variant, which was discovered by our own scientists through a lot of work around genomics and identifying the virus, this virus demonstrated some characteristics that made it not to have some of the vaccines or one of the vaccines being able to respond in a positive way to how the virus presents itself. And that is what has created a lot of discussion. A program director, I think I must pause there because I don't want to be the only person who talks. I've just set the scene. I can go into detail on each of the vaccines at some later stage, should I be required to clarify on each of the vaccines. Thank you.
No, thank you very much, Dr. Tulare. I think, it was good that you gave us that background, because I think the public doesn't understand the complexity behind the negotiations and, how this plays out on a global stage also. So I think it's good that you gave us that background. It gives more clarity to the public. So our next speaker, because I see Dr. Anban Pillay, the Deputy Director General in the Department of Health, may join us later. He's not here right now. So I'm going to go to you, Professor Kogie Naidoo, because I don't know now you're doctor or professor. I see both titles here. Deputy Director and Head of the TB Treatment Research Program at the Center for AIDS Program of Research in South Africa, CAPRISA, and an Honorary Associate Professor in the College of Health Sciences at UKZN. Dr. Naidoo's contribution to HIV and TB treatment spans over 2 decades. Dr. Naidoo was the lead on several CAPRISA studies that have shaped both local and international guidelines on TB HIV treatment integration. She has been a lead investigator in several phase 2 and phase 3 TB, HIV, and drug-resistant TB treatment trials. These include several international, multi-centered, multi-country, collaborative clinical trials. In 2013, she received the Union Scientific Prize for Scientific Contributions in TB, awarded by the International Union Against Tuberculosis and Lung Disease. It's a pleasure to have you, and you have the floor.
Thank you very much, Program Chair, and it's indeed an honor to be on this platform, as well as to share the platform with His Grace, the Archbishop, Dr. Tulare, Professor Jinabai, Professor Chetty, Dr. Moodley, Dr. Prithi, and others. I thank you very much for the invitation. And over the next 12 minutes, I plan to share some of my insights with you. So I have a few slides to share with you to provide some insights into vaccination. So I just want to get an indication that my slides are visible to you.
Yeah, we can see it. Go ahead.
Okay, all right. So I'm going to be discussing the public health impact of vaccination. I'm going to take you through what our history has been with vaccination over the last 2 centuries or so, and what are these implications for the COVID-19 pandemic. So why do we vaccinate? We vaccinate to prevent infection. And most importantly, we vaccinate to prevent disease and to prevent death. We would like to eradicate the pathogen, but that's not always possible. And some of the other benefits is to improve well-being of our population, to foster peace of mind and social mobility. We all can identify how difficult the lockdown has been and the impact of social mobility on each of us. And of course, we want to preserve the economy. We want to grow our economy and constantly maintain productivity of our citizens. So why are we vaccinating against COVID-19? We've had the flu year on year on year, yet vaccinations are available, but there isn't this huge drive to vaccinate. So this black picture at the top end of my slide is showing you these red dots against a black backdrop. And those red dots indicate the COVID-19 cases by country globally. Right now, we have 106 million cases, accounting for about 2.3 million deaths throughout the world. Here in our very own country, 1.5 million cases and about 46,000 deaths in South Africa. A slide that's been shown to the South African public by Professor Karim has shown even in the second wave, we have high rates of severe illness. You can see the shaded gray bar showing us the hospital admissions and the red line, the number of deaths with the second wave being even higher than with the first wave. So it's a huge problem. We need to vaccinate against this infection. It is causing unprecedented levels of infection. It is causing death amongst people across the age groups, and it is paralyzing our hospital services with hospital admissions. So how successful have vaccines been in preventing infection? You can see our very first experience with vaccines started with the smallpox vaccine in 1798. By then, smallpox had killed about 300 million people between the 6th and the 18th century. The vaccine was developed, but it took about 200 years for us to eradicate smallpox infection. So this human catastrophe of infection has been catalyzing vaccine development from as early on as 1798. There's been several vaccines that have been introduced subsequently, but to note a few, we had the Spanish flu about 100 years ago that infected about 500 million people throughout the world and resulted in about 50 to up to 100 million deaths in that 18 months in which it had the world in its grip. People either became infected or developed immunity to the Spanish flu, and no vaccine was created then. After that, we've had several vaccines such as the BCG, diphtheria vaccine for whooping cough, the measles vaccine, and so on. I'd like you to pay attention to the BCG vaccine. Our newborn babies, before leaving the hospital, are all administered a BCG vaccine over the upper arm. We see the scar as our children grow up. That vaccine is for tuberculosis, for prevention of tuberculosis. But we know we still see a lot of tuberculosis. So how this vaccine actually works is that it prevents TB meningitis in children, as well as a disseminated TB disease. So it's highly effective in doing that. And we see very little TB meningitis and this TB that is spread throughout the body in young children. And the BCG vaccine is the most powerful tool that we have that we use against it. Whooping cough, or diphtheria as it is been known, killed millions of people before the vaccine became available. But by 1980, we had about 100,000 deaths after we started the vaccination program. And by 2015, we've had only 4,000 deaths throughout the world from diphtheria. The polio vaccine has been another highly successful vaccine. These are drops that are administered under the tongue to little children, to newborns, and then as children grow up to under 5. And polio doesn't just kill, it causes paralysis that is irreversible. And so it causes a lot of disability, and it impacts the development of children and adults if they acquire polio. Now, polio has been eradicated from Africa. So there's no more polio cases as of 2020 as a result of this vaccine being available. We now in 2021 are faced with this COVID-19 pandemic that's affecting 219 countries. 4 candidate vaccines have had their data published in papers, peer-reviewed papers, and there are about 16 candidate vaccines in total that are in development. So how do we get to a vaccine? And I think understanding the scientific rigor that is implemented when we're testing any interventional product, anything that we're using for human health, is very important for the public to have this understanding. So you know that you're not getting a rushed product. Very often in the media, I hear that people are getting these vaccines and they are rushed products without the scientific rigor, and the data may not be valid, and so therefore it may not be safe. When someone or a drug company or a scientist has a product that they think is going to work against an infection or a disease, that product undergoes preclinical trials in animals, in small animals, to establish whether it actually works for that disease it is intended for, and whether it is safe and causes any major organ dysfunction. Once that has been established, that product then advances through clinical trial evaluation. The phase 1 trial usually involves a small number of adult participants where the dose of the product is established. So a phase 1 study is to say what is the right dose that we need to administer to create an effect. Also, we ascertain whether or not it is safe to use. Thereafter, once that has been established, the product then advances into a phase 2 study that usually involves several hundred people. Here, we specifically look for safety of the product as well as whether it is effective. Does it do what we intend it to do? Does it prevent infection? Does it treat a medical problem? So is it safe and is it effective? A phase 3 study usually involves thousands of participants. These are large studies. Very often in your phase 2 and 3 studies, you have a comparator group. The one group gets that product that you are evaluating, whereas the other group gets what we call a placebo, which could be saline or a vitamin tablet or something that is not the interventional product. During these phase 1 to 3 studies, that are all undertaken in human participants, there is much attention paid to monitoring the safety of the participants. For that, you have an independent safety committee that's external to the study. You may even have a protocol safety committee within the study. And there is an independent body that reviews the data at periodic intervals to tell that group of people that are conducting the evaluation whether it is safe to continue or whether the study needs to be stopped. Once all of this has been implemented, all the data on that particular investigational product is then submitted to regulatory authorities for licensure, like the United States Food and Drug Administration, the FDA, the South African Health Products Regulatory Authority, SAHPRA. These are regulators. So they get this dossier of information from the preclinical trials all the way to the phase 3 trials in order to make an assessment of whether this product does what it is intended to do. Is it safe? Is it effective? And has the quality standards in manufacturing that product been maintained? Once SAHPRA reviews this dossier, independent policymakers like our Ministry of Health makes a decision whether or not to adopt that product into the health program for provision to the general public. Once the products go into the community, ongoing monitoring for safety and effectiveness in a large scale, we call effectiveness. So in a real world operational setting, how does this product do? So that's what happens in a phase 4. So what I now need to say to you is that the COVID-19 vaccines underwent the exact same path. No shortcuts were taken. Thousands of patients, tens of thousands of patients were evaluated. It was a huge global effort to find an answer in order to mitigate the impact of COVID. We got an answer quickly because it was such a huge effort by scientists and doctors, nurses, clinical trialists, and so on. and several candidate COVID-19 vaccine products were all tested at the same time. So we spoke, Dr. Tulare spoke about creating herd immunity. And to many people, this is a mystic, the term herd immunity is very much a mystery. So I'm going to try with my graphic to dispel some of that mystery. So if you look at the top three, A, B, and C, A is lots of blue men. So I'm going to call them men and not women, so please forgive me for saying that they're men. So these are what we call a naive population, meaning they've had no prior exposure to an infection and they've had no prior vaccine for that infection. So they are what we call susceptible, so that they stand a high risk of getting that particular infection. So in this instance, for COVID, the blue bodies are those that were not previously infected and had not taken a vaccine. The red person is the infected person. And that person now, as you can see with the arrows, spreads the infection from person to person, unchecked in that community. And you can see it in blue, where increasing numbers of people acquire the infection from the first person in A. Now you go to 3 in B, with one that's turning peach, which shows they've had infection in the past, and so they have some immunity to the infection. By the time you get to C, you can see there's far more people that have immunity, but also far more people that are now infected. We now move to getting herd immunity. The number of people that are peach is increasing, meaning that they have now acquired some either an infection or they've acquired a vaccine, so they have some protection against against COVID infection. So the guy in red can't transmit to the other people because they've either got previous immunity or have received previous infection or have received a vaccine themselves. So they're not at risk of acquiring infection, meaning there's fewer susceptible people. As a result of fewer susceptible people, you get the spread of infection being lower and indirect protection for the other people within the community. So overall, this results in fewer new cases. So remember, your peach occurs as a result of vaccination. So you're acquiring immunity artificially through a vaccine or from acquiring an infection yourself and getting COVID-19 and then getting susceptibility thereafter. So this herd immunity now is achieved when the spread of infection from person to person becomes contained because you have a reduced number of susceptible individuals. So how have we done for vaccines in preventing death? Late in 2020, so I apologize, Madam Chair, that this looks a bit sciencey, but for people to
Professor
understand.
Naidoo, why don't you hit slideshow? It will come up bigger.
For some reason, it's not doing that. I beg your pardon, okay. But it's just, I tried from the beginning, but it doesn't seem to do that.
No problem, go ahead.
Thank you. So we've had about, the top 10 pathogens that cause an infectious disease were examined by this vaccine impact modeling consortium that looked at vaccine data from 98 low and middle income countries. So they looked at uptake of vaccines across these countries, and they looked at estimates of death that's been averted across each of these countries, and then the number of deaths averted by each calendar year from the year 2000 to 2020 and then modeled to 2030 to get an assessment of the impact of vaccination against these 10 pathogens. What they found is approximately 40 million deaths were avoided since the year 2000, and that there was increased vaccination coverage over time, and that those individuals that were born in 2019 have a reduced lifetime risk of dying from one of these infectious diseases by about 72%. I mean, that's staggering. So this is telling you that vaccines prevent death, and effective vaccination achieves the goal that it sets out to do. And a child mortality report also that came out late last year also shows that children that are now born today stand a far better chance of surviving to age 5 than someone born in 1990. So this slide now compares in the middle the various COVID-19 vaccines that are available with published data against the other vaccines that have been around for a while there in our community. So the first 3 bars tells us the vaccine efficacy of the seasonal flu vaccines that are administered during each flu season. The low efficacy of 1945 and 60 is because people simply don't take the flu vaccine. It is not something that poor people can afford usually. And so the access has not been as wonderful as we wanted it to be. But by 2019, of course, we found that far more people took it compared to 2014, 2015. When we go to the other end, to the German measles and measles, as well as the polio, the vaccine effectiveness, so effectiveness is in the real world setting, right, has been very high, exceeding 97, 99%. And you can see that the vaccine effectiveness of these COVID-19 vaccines are extremely comparable to the other vaccines that we've had in our childhood immunization schedule to date. So does the vaccines that we have, that South Africa is considering, prevent against hospitalization, and does it prevent against severe illness? I am drawing your attention to the first column, which has been widely presented, the efficacy in actually preventing infection. So you can see that some of the data that have been reported are the global data, but very little data is available for South Africa in the presence of the variant. And what we know is in the presence of the variant, the Johnson & Johnson vaccine is 57% effective, the AstraZeneca vaccine 22% effective, and Novavax 49% effective, which is far lower than the vaccine efficacy found globally. But what's important is that these vaccines, even the Johnson & Johnson in South Africa, is extremely effective in preventing severe disease. Ultimately, I'm okay with getting COVID infection if I know I'm not going to land in hospital and I'm not going to die. Ultimately, like BCG did for TB, didn't prevent TB, but it prevented the serious complications from tuberculosis. So we find that the Johnson & Johnson, although in South Africa the efficacy was lower, it was highly effective in preventing hospitalization and preventing disease. And they've got really good data to support this. Of course, the paper isn't published, and we need to wait to see that, to see the real data. While efficacy globally has been reported at very close to 100% for most of the other vaccines in preventing severe disease, we actually don't have data for South Africa. And that is a space that we may or may not have in the future. But I know a lot of laboratory studies have been undertaken to show that the Pfizer vaccine is indeed effective against the strain, the 501YV2, but we don't have data on preventing severe disease here in South Africa. If you look at the number of participants, sample size refers to the number of participants that took the vaccines or the placebo in these studies. And you can see they range from 15,000 to 44,000 people. So these were not small rushed studies. These were large studies providing us with a wealth of data. What we know is that the side effects that patients complained of were largely related to the injection site reaction, pain, redness, swelling, and so on. So it was all at the injection site, both in the intervention and in the placebo group. So even those that did not take the vaccine also complained of these side effects. Headache and fatigue were the other common side effects. So this is giving you a snapshot of vaccines and their ability to prevent infection and prevent severe disease, and what are the anticipated side effects from vaccines based on the studies that have been done thus far. We know that vaccine gives us other benefits. It lowers the cost of healthcare to treat disease that can be prevented. So if you prevent, you don't get the disease, you don't get the infection, your overall costs of caring within the health system and for families are lower. There's lower catastrophic costs, right? So people dying and being admitted, loss of income, thereby minimizing the impact on families. We know from data that children live longer and they themselves become breadwinners. The estimation is that there's a 53% reduction in under 5 mortality just by the childhood immunization campaign. We know through vaccination, communities benefit through the shared immunity. There's far fewer outbreaks of disease and less disruption to trade, to our tourism, and all of this just benefits our national economy. We know that we improve health outcomes and societal well-being. When people move around, they feel happier and they have better mental health. So my concluding remarks are that vaccines are an integral part of preventive healthcare, and it has been for centuries. It's used globally for immunization, and it is used to protect travelers. The main goal of vaccination is to prevent infection, severe illness, and death. We've had a large number of COVID infections, hospitalization, and death, and that is underpinning our drive for COVID vaccination. We need to help and save our people. There are several candidates that are now available with imminent rollout to the South African public. Thank you very much. Thanks.
Thank you very much, Professor Naidoo. I can see that Caprisa runs a course on how to do presentations and put slides together. I see Professor Karim has that, and I see you have it also. So very interesting slides. I let you go for a little longer because I think that was the information that the public needed and needed it to be deconstructed. And I think you deconstructed it in a nice way. I think you also alerted us to the dangers and you gave us a good historical sense, you know, going all the way back to 1798. It puts it in perspective. It's a little bit scary that, you know, we lost 50 to 100 million people in the last virus in 1918. Of course, we have more science today and we have better facilities and we can save more lives and we have to take the vaccine. I think that was the real message that you gave in the end. And that statistic you gave about children being born in 2019 is just amazing. I mean, I was mind-boggled by that statistic that these kids would have 72% mortality rate. I mean, that's really, really good. So I think, you know, there's a lot of evidence as to why we should take the vaccine. Now, I'm going to switch, you know, because firstly, there is a question that came through. I want both yourself, it's to you and Dr. Tulare. So just note the question and then you can answer it later. It says, thank you, Dr. Tulare, Professor Kogie, but surely the AstraZeneca vaccine can still cover our South African population against variant 1. I think that's the pre-variant thing. With the J&J vaccine coming in on trial for healthcare workers, Let us use the AstraZeneca Oxford vaccine in the meantime for the general public. That's Dr. Anban Pillay from the Tonga Benito IPA. I take it that's the Independent Practitioners Association chairperson of the Tonga Benito branch. So save that question, because I'm going to bring at this stage one of the moral voices of our society, a leader in our society, and someone we all look up to for guidance in times of trouble, whether it's political trouble or health trouble. Your Grace, you are a moral voice in our society. We look to you for guidance in these difficult times, and we know that you also represent the voice of many people. So you've listened to the two presentations thus far. I'm going to ask you whether there's a comment or a question you want to put to our eminent specialists.
Thank you so much, Vasu, and to the eminent specialist. When you said I must make a comment, I got worried yesterday. I thought, are you referring to my cousin William Makhoba or the cleric Tawa Makhoba? But at least your introduction is quite helpful. I'm really grateful to the presentations, and really as a spiritual leader, my role is to be a cheerleader to South Africans, to say, come on, we can do it, or we're messing it up. Let's pick up where we have left and move on. So the presentations today are very stimulating, very encouraging, and I can hear the detail that is necessary to be out there, and seeing that Gandhi is the Gandhi Trust, yes, is co-sponsoring the talks today. I just wanted to really quote him today. He says it is health that is real wealth, and not pieces of gold and silver. And so today I was hearing that it is not silver or gold that we're talking about. We're talking about health. And he also says, please see the good in people and help them. And so the specialists today have underscored those two principles that Gandhi talks about. But I want to ask, just a simple question to them, and a comment to say, in the light of what Gandhi says, see the good in people and help them. What is happening in the hospital in KwaMashu, which is in the news, and how are we going to deal with some of those practical things that are happening on the ground? And the other comment is, if this is a global pandemic, surely it needs a global action. Why are we now moving into national interventions, national efficacies? And I thought efficacy is efficacy, or whether the drug works, should work regardless. And now for the last point, for the pro-life people of any faith, the question of where the trials were conducted poses a major moral dilemma. And we know that some of the vaccines are said to be done with the linings of aborted fetus. What do we do, and how do we address the pro-life people that are concerned about that. So Vasu, those are some of the questions that I hear every day that I wanted to weave into the discussions as we go forward. But my main message is I am proud to be a South Africans, and I'm proud of our scientists.
Sorry, I think we dropped Advocate Gandhi. I'm sure he'll come back on now.
Okay.
Professor Jinambai.
Thank you very much. Just a quick announcement to all our participants and people who are listening. We have the Q&A, the question and answer session that is now open. We'd like to appeal to all of you to use the Q&A session and also to put all your concerns, your questions to our panelists and to our experts. So that's the first comment I want to make. To follow on the previous two presentations, and specifically the comments from His Grace and our spiritual leader, and thank you for guiding us and showing the light, and also reflecting on the teachings and the philosophy of Mahatma Gandhi. And it's important to bring that in, because what I'm going to be briefly talking about, Vasu, is that okay if I can continue?
Yeah, Noddy, go ahead.
Okay, thank you. So
it wasn't divine intervention, it was just ESCOM that knocked me out.
Okay, thank you. So I'm going to very briefly touch on a very fundamental and important aspect that His Grace, our Archbishop, has touched on, and which is underpinning the previous two presentations from Dr. Tulare, as well as particularly the presentation from Professor Kogie Naidoo. And that is that we need to, what both of them talked about was the natural history of infections, the virus, bacteria, fungus, etc., all the microorganisms, and the natural history of all those elements and how they are spread and how they eventually result in disease, disability, and death. That was the first two presentations. What I'm going to talk about is social compact, and that is that we need to recognize and acknowledge that in South Africa, our government has undertaken what we call a developmental state and a developmental approach. Also, in the academic sector and in the labor, social sector, NEDLAC, in the government sectors and all the other bodies that interact between government, the business sector, society, the NGO sector, and the CBO sector, we have the notion of a social compact. And fundamentally, what it means, very simply, is that if we're going to defeat the COVID virus and any other virus and pandemics, and remember, we are going to be having in future other emerging pathogens, emerging germs, and emerging diseases. So if we are going to defeat this particular COVID virus with its variants and mutations, etc., then it is the responsibility of every single member of society. That is, all of us have to understand that our roles and responsibilities co-merge and we are co-creators of our destiny. And that is what the Archbishop was talking about when he was quoting, making comments, and also quoting Mahatma Gandhi. Social compact means, and if you take Kogie's presentation, there are different phases to the disease. The first two phases, which are fundamental, are prevention and health promotion. So prevention and health promotion are fundamentally the responsibilities of each of the 50 million citizens of South Africa and the 1 billion citizens of Africa and the 7 or 8 billion people. So it's only individuals and their families who are willing to change their social and their behavioral characteristics and who are willing to undertake certain actions such as the wearing of masks, social distancing, sanitizing, and the preventive measures, it is the first step and the most important step is prevention at an individual level. And therefore, as part of the social compact, we as individuals, and of course, through us as individuals, our families and our communities have a primary core responsibility and duty for prevention of that infection. The next element is health promotion. And health promotion is part of social distancing. That is, if we behave and conduct ourselves in a certain manner, we prevent the spread of the disease from ourselves as an individual who may be symptomatic or even asymptomatic, meaning that we have the infection, but we don't know. And this is the problem with this COVID virus. And that is that particularly in the young adult population, the younger adults, we find that they may have the virus, they may have been infected, but they may be largely asymptomatic or have very few symptoms. And as a result, they're not aware. And therefore, they have the potential, as Kogie showed us very nicely in those 6 diagrams, to continue to spread the virus by certain kinds of behavior, crowds, gatherings, drinking, binge parties, social gatherings, etc., etc. So the first aspect is prevention. The second aspect is health promotion, where we individually and collectively at a community level, at a family level, begin to conduct ourselves in mitigating and preventing the spread. And that's part of the social compact. Of course, what I'm saying is if we talk about prevention and promotion, then if and when people get infected, then the next element comes in, which is treatment, cure, and support, which is where the health system and the government comes in. And they have been obviously quite rightly playing a leading role in mitigating the impact of the epidemic through the provision of health services and various other things, including the topic we're discussing today, which is to acquire the various vaccines and the vaccination of the 65% of our population to achieve herd immunity. So that's the natural history of this particular virus, but all diseases: prevention, promotion, and then if and when people are infected, early detection. And early detection also is a key part of the social compact, from individuals, families, and communities to be alert to the symptoms, which we've been sharing widely, disseminating through the various media, social media platforms, etc. And by early detection, we're able to then take corrective measures early, go and seek treatment early, and prevent further spread. And of course, eventually when people require hospital care, clinic care, health care, medical care, ICU care, we are then able to provide that in the public and the private sector. So the notion of social compact is fundamental to the approach that we in the Phoenix Settlement Trust and in many of our non-governmental organizations and community-based organizations. And this is the appeal that we would like to make to all the NGO and CBO sectors that are working at a community level and at a family level. That is to then share with them how we are going to go about breaking this circle, this vicious circle of the spread of the virus, having understood the natural history, understanding the different stages of the spread of this particular infection, and making sure that we all, as part of the social compact, as all stakeholders, we play our part, not just expecting doctors and ICU nurses and ICUs and drugs and vaccines. That's not the only solution. They have a very important role to play in preventing severe disease, preventing death and mortality, and also treating and care and support. That is true, but that is on the other end of the spectrum. The first end of the spectrum, from a community-based perspective, is prevention and health promotion, and that is all our collective responsibility. And that is fundamental to the notion of solidarity, which is part of our developmental state approach of our government on the one hand, but also very fundamental to the notion of Ubuntu. A key feature of our Rainbow Nations is Ubuntu. I am because of you, you are because of me. And that if we're going to defeat the virus, we need to go back to our roots in Ubuntu and all the spiritual and religious traditions that the Archbishop talked about. And we need to find strength and courage. We need to revisit those teachings and the principles of our spiritual organizations and about Ubuntu. And we need to ask, what is it that I can do? What behavior must I change to ensure that I do not contribute to the further spread of this epidemic? What behavior change must I undertake at a family level and then ultimately at the community level? And how can I promote health and ensure that we break the cycle of transmission of the virus from person to person, families to communities, and of course, globally, etc. As you probably all know, all international travel between South Africa and the globe has been completely stopped, and in many other countries, and that's part of the challenge. So in conclusion, I just like to share with the audience that we need to reflect on Ubuntu as a fundamental way to go forward. I know our Archbishop is an excellent proponent of that. Gandhi has been a champion for 8 decades in South Africa and globally in Ubuntu and in the Gandhian philosophy of sharing and caring and being the agent for change for all of us. So those are the fundamental social and philosophical aspects that we need to consider, and fundamentally spiritual aspects if you're going to break this chain. So back to, I will conclude with that, and I would like to hand back to Advocate Vasu Goundan.
Thank you very much, Professor Jinabai. And I've known Professor Jinabai for over 40 years. He's really the specialist on community and public health, and comes at it with just the most progressive outlook to how we should deal with community and public health. So thank you very much, Professor Jinabai, for putting that in perspective, that it's about individual responsibility. The vaccine is there. We will get the vaccine. We may get it, we may not get it immediately, but we can save lives through our own behavior. So it is about individual responsibility, and it starts in the family. It starts with every single one of us. And Your Grace, I missed part of your speech, thanks to Eskom. But I did catch the part in the chat group, global pandemic needs global action. And, I think you're completely correct. We need to have a global movement to deal with this issue of producing vaccines for our people instead of producing vaccines for all people. And I've said, recently, what moral compass are we using as humanity that we spend billions on building fighter jets when we should be spending billions on hospitals and ventilators? So we really need to reset the way we deal with our value, the way we espouse our values as humanity. Now, I want to, welcome also Ella Gandhi. Ella, I know you couldn't make it because of Eskom knocked down the tower. So we're very grateful you're here, and we've had a really, really great discussion so far. And I'm going to ask you at some point to make some concluding remarks, but I'll give you a chance to just listen in to some of the other inputs. We have Dr. Tulare and Professor Naidoo. I will give you an opportunity also shortly to make some inputs. But we have a few people. There's Musi Masuku from Osisa, whom I am going to ask you, Musi, if you have a question or two. Nonchalansa Shange from the SOS Children's Village here. And we know that a number of these homes, whether it's old age homes or orphanages, etc., are quite affected by the virus. We have Maseko Leboto from Harmony Gold, who's here, and we know our mines, which is really also contributes heavily to our GDP, is also affected quite a bit, how they're dealing with it there and the questions you might have. And then we know the media has a lot of questions, so we're very happy, Nathan, that you've joined us. Nathan Craig from the Sunday Tribune. So if you have a question or two, we'll give you an opportunity. And then we have 3 practitioners on the front line. And they will be here also to add in and give their inputs. The first is Dr. Prithvi Ramlochan, very well known in the Durban area. Everybody knows Dr. Ramlochan, a family practitioner. and a frontline general practitioner of the Durban Independent Practitioners Association. Dr. Ramlochan is the director and the founder of the Newqua Sexual Health and Wellness Center. He has served as chairman of the Durban Doctors Guild since 2000 and as the chairman of the Pharmaceutical and Therapeutics Committee of KwaZulu-Natal and the Managed Care Coalition. And then we also have Professor Chetty. I'm not sure he's joined us. Eskom also knocked him out. But Professor Chetty is the CEO of the KZN Managed Care Coalition and is part of the vaccine rollout team. Professor Chetty is the chairman of the IPA. He's an associate professor of research at the Durban University of Technology. So it would be very important to learn from, or to hear from Professor Chetty about how they're going to roll out the vaccines. And therefore we have also Dr. Mags Moodley, who's a family practitioner, also very well known, been with us in the struggle for a long time. And we are so grateful that you made it through the virus, Mags. And I think we want you to speak also as a survivor, because you spend quite a bit of time. And I know I chatted with you earlier, you're still recovering after having spent almost a month now. So you can give people, you know, your real experience, but you are also involved in the vaccine rollout. And we want to know, how is this thing going to be rolled out? Do you have a system in place? We know about the app that is there, but you know, we want to know, how will you roll this vaccine out? What is the plan to do this? So I'm going to start by going to Dr. Ramlochan, if you have a few inputs, and then I'll go to you, Mags, and then Muzi, I'll come to you and go to Nonslanstra. So Dr. Ramlochan, if you have a few brief comments.
Thank you, Vasu, and thanks for that. I'm going to keep it brief because I think we need the community to ask and really bring all their queries to light. But the question every day in the practice is, doctor, are you going to take this vaccine? And if so, why do you want to take this vaccine? You've had COVID already. Your wife was ill. She was on a ventilator. Why do you need to take this vaccine? You've already had the infection. And so the conversation every day is with our people out there who are so interested in the vaccine and so interested in knowing about the vaccine, so they have informed and can make informed processes when they want to decide about the vaccine. And when you start to explain that this is a we process, not a me or you process, it's a we process. I am taking the vaccine and I want to take it so I protect you. And suddenly he says, but you're not protecting me. And I says, yeah, I will. Because if I take the vaccine and I'm going to be the frontline healthcare worker who takes it first, you're going to get the protection from me. And therefore, you're going to be protected from me. And if you take your vaccine, I'll be protected from you. And therefore, we can now start to protect our whole community and our whole country and our whole world. And we can suddenly bring it home. And their eyes light up to say, but Doc, why are you saying that? I mean, you should be selfish and say, well, you had the thing, you're safe and whatever. And I said, that's the beauty about vaccination and what it does. And it was very well alluded by Prof. Kogie to say this is a story, and Prof. Jinabai and Aquina to say this is how we see the whole process. And this is the daily thing. And then, but Doc, how are we going to roll this out? You know, there's so many people. And I said, you know, you must have faith. In our country, we vote 20 million of us in one day. The IEC runs one election, 20 million people in one day. If we had all the power and the money, we'll give you 20 million vaccines in one day. You think that's possible? Yes, it is. Have faith. Have faith that we will roll this vaccine out in the stages decided, and we'll make sure that it'll happen. So, Doc, is your center going to be a vaccine center? I have done my vaccination course. I await the details that will be rolled out soon for us to vaccinate. So, yes, we will vaccinate. Yes, I will be at the front line of getting vaccinated. And it doesn't matter whether you had the infection before or not, you should vaccinate. There is no preclusion to you not getting the vaccine. But so I'll leave it there because that's my simple message of my conversations daily with all my patients and fellow colleagues. Thank you.
Great, thanks. Thank you very much, Dr. Professor Chetty, you are with us, I see. Have you survived ESCOM? Okay, yeah. I think whilst we wait for Professor Chetty, Mags, why don't you go? We're so happy you survived. So tell us how you survived first. You're looking healthy.
Well, it just proves that no one is immune from this virus. This virus has been around for 13 months. If you look at the first indication of it in 2019 of December. And we thought it's going to be just in China. January, we had some meetings about a pneumonia in China, which we didn't take too much attention to until February came around. But the first wave we were prepared for because we had the lockdowns. The worldwide went with the lockdowns. The second wave with the new variant in our country is what took us by surprise. Took our scientists by surprise, took all of us by surprise, because we thought that the second wave will be a bounce of a dead cat. In other words, smaller than the first wave, and we can manage it. But it seems it was more virulent and faster spreading. And as I said, no matter what we did, we had full PPEs, everything else, but some of us did get it. I'm fortunate in fact that I survived. Lots of my colleagues didn't survive. And there's, we see the list out on social media of all the doctors that haven't survived. Just today, we lost one of our eminent, it's a cardiologist from the Nkosi Albert Lutuli Hospital, Dr. It's Leslie Punasamy, who succumbed to it one today. So how did I survive? Well, I recognize the symptoms. It's the same sort of thing which we tell our patients. Look at your oxygen saturation, look at your symptoms, your breathing, etc. And when I found out that, my breathing was getting labored, the first thing I did was what we tell our patients, get an X-ray done, and obviously it showed COVID pneumonia. At that stage, obviously I had to admit myself because my stats were dropping. I was fortunate to have good specialists and physicians, a team of them to actually treat me. I was fortunate to go on to a drug called remdesivir, which helped to help with the viral stage, and of course the blood thinners and the steroids. People must understand that you have an incubation stage or asymptomatic stage of 5 days, which you can still pass it on, a viremic stage of what we say the virus is spreading in your body for about 10 days. The thing that is killing patients and killing people is the inflammatory stage, which is what probably people would have known. It's called a cytokine storm, where your body actually goes into overdrive to kill off the virus. And your immune system actually does more damage. And then you get the blood clotting problems and the lung issues and the secondary infections. So as I said, I was quite fortunate. In the viremic stages, I did well. Came out and didn't realize, not that I didn't realize, the second stage of the inflammatory response actually did more damage than the virus itself. But because of good it is medical knowledge and good treatment from the team, I did survive. But I'm what is termed with quite a lot of other patients called long COVID. Most people, as you can see by today's stats, our recovery rate is 90%. So 90% of our people who had COVID have survived and recovered quite well. Some went to hospitals and some succumbed to it. So the long COVID is the symptoms that can persist for over 10 days, 14 days, can go up to 3 months, or at times 6 months. People should remember that this virus has been in the human population for 1 year only. So experts and professors all over the world, it's a learning curve, and we're learning new things on it every day. The fact that for the first time, people who never had type 2 diabetes can get diabetes. It causes changes in your lung, it can cause changes in your lymph nodes, can cause changes in your pancreas and in your brain. So there is centers all over the world that is finding newer things that this virus is causing, which makes it seems that is not what people thought initially. Oh, this is a flu, simple flu, like the H1N1, the swine flu. We got worried about in the first 2 years. We had a vaccine, and now swine flu is part of the normal flu season. This is not that. This is a deadly virus that attacks every system in the body, including your toes and your fingers. We have a thing called COVID toes, where you get decreased flow of blood. But there is protocols in place, which doctors know, family practitioners know, GPs and specialists know, that can tell the patients, these are the things you have to do. These are the things you have to look out for and seek help if certain things change. So education of the population, education of our patients is fundamental to prevent long COVID or to prevent side effects of the medication or to prevent worsening of the condition. As I said, I survived because I followed certain protocols and of course because of our team approach, which is available to most people, and is available to people who keep in touch with the primary care, with doctors, primary care, with nurses. We have enough knowledge now to know exactly the history of the virus, of the infection, and where the infection can proceed to. We're not talking about the hospitalization and ICUs, but on the average person that can get quite sick to day 14 to day 20 with myalgia, weakness, tiredness. There are certain protocols in place on breathing, on physiotherapy, on getting back to exercise. What we know, we tell people, if people probably, the population, public probably knows that when we have the flu, normal flu season in June, July, we always tell people don't go to the gym, don't exercise, don't strain your body. This is your average normal winter flu. And there's a simple reason for that. Because if you do that, we increase the spread of the virus, the common flu virus, to your heart, your lungs, and things like that. Sometimes we hear quite healthy people in the gym who had the flu and collapsed and died. The same thing happens with COVID. It can affect your heart, and you can have sudden heart attacks, sudden heart failure if you do not rest. In other words, if you think, okay, day 14, I can do my jogging, we tell the people, take 1-2 months to actually get your system back into place. So there's a graded response to coming back into full exercise performance and work performance. So we actually have those sort of things. The other thing I want to talk about, which our Holiness the Bishop brought up, was the cells and aborted fetuses and the Right to Life campaign. Sort of people who are worried that the vaccines are grown on aborted fetuses. So, and of course, the internet is full of conspiracy theories and stuff like that on this fact that these vaccines were manufactured using aborted fetuses. In the 60s and the 70s, we had aborted fetuses. It's a genetic line which we grew the vaccines on, and we grew viruses on to make our vaccines. And we are not using those original ones. We're using what we call the stem cell lines or the genetic lines from those original cells. So we are not using aborted cells at the moment, aborted fetal cells at the moment to grow the vaccines. The adenovirus is a common flu virus. So the AstraZeneca vaccine was actually grown on the DNAs of adenovirus. So there was no fetus involvement and stuff like that. The third thing is what Dr. Priddy said, was that every healthcare worker is an advocate of the vaccine. Every healthcare worker is an advocate of educating our people, educating the population against why there's a need to take the vaccine. People ask me, yes, Dr. Moodley, you were sick in hospital, you had COVID pneumonia, are you going to take the vaccine? I said, definitely yes. Just like Dr. Ramlochan said. But why? Because exactly what he said, we want to protect ourselves, we want to protect our people. Because vaccines scientifically has been proven over the centuries to be our only protection against certain germs and spread of infections. But isn't there any side effects? And we explain to them, yes, everything has this one side effect. How it's going to be one role that we tell them, the government has things in place. The private sector we are rolling out it in the private sector because the medical aids are going to pay for it. Fortunately, some of the Mediclades are saying, if you buy 4 million vaccines for our Discovery or Momentum or GEMS patients, they're going to give 4 million back to the state. So it's a win-win situation between the private sector and the public sector. And the private sector, as GPs and family practitioners, we are putting things in place to actually ensure that the private sector patients have access to the vaccine. As you know, you look at the list, it's going to be the private hospitals, the state hospitals, the community pharmacies, the network pharmacies, etc. As some people may know, that we are called vaccinators. We go through a course run by the Department of Health. So it's not just, hey, just poking a person in your arm is, that's not rocket science. We're poking people all the time with Voltaren and your medications. But there's a specific way in which the vaccine rollout is going to be done in the public and private sector. That's why there's, in the last few months, and it's going to go on for the next few months, on the education and the training of vaccinators, nurses, doctors, and all that. Because this is a specific thing about how the vaccine is going to be stored, how it's going to be transported, how we're going to separate the patients. There are going to be two sort of places to wait. Those patients, remember, these patients are not patients who have symptoms. They're not going to be sick patients. These are going to be healthy patients, healthy people that are going to come for the vaccine. They'll have to follow a queue. They'll have to have the ID book. The Department of Health and our government have done excellent work in ensuring that everyone is barcoded and is told that it's captured, like how we do when we go to vote, and everyone's getting SMS to if they need to come back in 4 weeks' time for the second dosage. Things are in place. It may not work 100%, but it probably work between 95%. And the vaccinators have to know that exactly how it's going to run. Even after we give them the vaccine, they'll have to join another waiting area with social distancing to ensure that there's no anaphylactic reaction. In other words, there's no allergic reaction to the vaccine. It's quite rare. The normal thing is your pain and swelling around the vaccine site, but there may be some people that may faint, may collapse, may have a serious one-on-one reaction. So we are training the doctors and nurses, and doctors and nurses are being trained to ensure that if anyone, unfortunately, has to have a severe reaction, there's a way to resuscitate them with oxygen and etc. But the majority of people are not going to have any problems. So there'll be a waiting area post-vaccination. After 15 to 20 minutes or half an hour, if you're fine, you go home. You had your vaccine. We are hoping that people make badges for themselves and said, I've taken the COVID vaccine. It's going to be, we're trying to tell people that please be proud that you have taken the vaccine, because it's not to protect you, it's to protect society, to protect the world. So that's the program we're having. We're gonna piggyback onto the state's program, which is going to run quite effectively. Most of the hospitals, state hospitals, are gearing up for it. Today would have been the day we had the rollout at the major hospitals. Unfortunately, it's going to be delayed until we get the Johnson & Johnson it's a vaccine, and it's going to be something never in the history of kind has there been such a massive rollout of a vaccine worldwide, in our country and worldwide. Never before have we seen this in such a short period of time. So it's a historical thing. It's a global historical process which we are going to see, and I think every one of us should be proud that we're actually going to be part of this entire. It's a vaccine rollout to our people. The last thing I would like to say is the conspiracy theories, which we as frontline workers obviously will have to be engaged with our patients and ask us about different conspiracy, because the internet is full of that, and all of us who are pro-vaccine, who want to see this thing be a success, to actually be a agitator and an activist to tell the truth. So basically, we should be truth activists. We've been through different struggles in the past. This is another struggle that we need to engage with, and we can do it. And the sense of optimism which we need to engage with our public is something which we have to do. Say, we can do this. We've done we've been through worse in the past. And this is something which, as a united one country, united world, we can do. Of course, you know, I mean, there's our debates about global or nationalization of the vaccine and the poor versus the rich one countries. But having said all that, it's going to be a global humankind push to actually have those things done. Thank you.
No, thank you very much, Mags. Dr. Tulara, there's a question here about, does the vaccine cause infertility, which I think is a very valid question many people might have. That. So whilst you're thinking about that, I'm going to ask Nathan Craig, who's with the Sunday Tribune. Nathan, do you have a question? And then Masakolo Loboto, of course, with the Harmony Gold, I'm sure your minds have lots of problems also. So Nathan, starting with you, do you have a question? You can switch on your camera, and Masakolo, you can switch on your camera. You'll come straight after Nathan, and then we'll go to Dr. Tulara, who will answer the question on fertility, infertility, and if you have questions for her also. So Nathan, starting with you.
Hi everyone. Can everybody hear me?
Switch your camera on, Nathan, then we know we're not talking to a robot.
I'm not too sure how great it's going to be. I'm in the midst.
You're good. Carry on.
I'm in the midst of load shedding. So I'm using a charged laptop and the data off of my phone. So if there's a black background, I'm not in the woods somewhere. I'm at home. So the big question that a lot of people are probably going to be concerned about, especially with what the health minister and experts have said in the past, is we might not be in the midst of, say, a third wave, but we need to act as though we are prepared for it. And the question then is, are we going to vaccinate in time that it's going to be able to defeat the third wave? Or are all the efforts that we're putting in to this vaccination going to be nullified if a third wave is driven by a new variant? So the question that I would like to ask the experts is, in the event, we've already seen it now with the AstraZeneca, and we're having to migrate to the Johnson & Johnson. Have we had any idea of, even though we have to be optimistic, the realism of it all? Will we be able to reach that herd immunity before a third wave? And additionally, if we're looking at all these vaccinations that we are going to try and roll out, the global average is much lower than what we are going to have to be achieving in order to reach that 40 million by, say, end of the year. Because if we look at places like the UK and the US, they were at peak, maybe breaching, let's say 50,000 to maybe 100,000 vaccinations a day. And if we were to look at the projections just to get the healthcare workers done, we needed to vaccinate maybe 300,000. So that's just health workers for the vaccines that we had for that batch. But now when we're having to look at vaccinating about 40 million people and we can only do, say, 50 to 100,000 per day, it starts to put this feeling of dread where you start to wonder, are we going to achieve this? And I'd really like to ask the experts, when we're looking at this, how do you not only beat this vaccine, but the psychological warfare that's happening within yourselves as healthcare workers on the front line, where you're having to think, I have to push ahead, but for how long can I hold back the tidal wave?
No, very, very valid questions, Nathan. And I'm going to ask Dr. Tulara to think about that whilst we get Masakolo. Masakolo, switch your camera on and unmute. Obviously the minds have serious problems. We'd like to, briefly, if you have a question. Masakolo, are you there? Okay, maybe we'll get back to Masakolo. Dr. Tulare, the question for you about infertility, and then the questions that Nathan had, which I think are, some of the things people are worried about. Dr. Tulare, you have to unmute. Ah, there you are. Okay.
Thank you very much for the questions, and I would also want to respond to a question that was posed by the Archbishop, the Most Reverend Makgoba, on the global action. Let me start with the question around the vaccine and infertility. And we know that, there have been a lot of people who are concerned about vaccination for COVID that have raised concerns around the possibility of the vaccine working against the placenta through the spike protein activity of the vaccine. But we know that work has been done around this by several of our scientists who have indicated that the spike protein of the virus and the placental protein are not similar. So there is no indication that these spike proteins would act like the anti-placental antibodies. So in response, just briefly to say that, there is a science behind explaining that there is no correlation between infertility and the vaccination itself. And would want everyone to be assured of this and to participate in the vaccination effort. I want to also respond to the point that was raised by the Archbishop on whether, are we dealing with the virus and the pandemic in a concerted effort from a global perspective. And I would want to say that, the past 18 months have taught us a lot of lessons around the fact that although we reside in different contexts globally, we are intertwined with respect to our health systems and the types of interventions that we need to implement as a global community. And there are various mechanisms that have been developed to deal with this. One of these mechanisms is what we call the Access to COVID-19 Tool Accelerator, which is a process that is developed at a global multilateral level. Our country is leading this process, co-chairing through our Minister of Health with a Minister of Norway in driving a global agenda. We know that, for example, through the WHO, we've got the COVAX facility, where various countries are participating. Through the African Union, we've created mechanisms for mobilizing vaccines for poor parts of the world. We are working through other mechanisms, including through the G20, which we participate in, where there's been commitments made to assist nation states in fighting the pandemic, and also in making sure that we come up with all sorts of other technological interventions that are going to ensure that there's equitable access to COVID-19 interventions. So there are various instruments that have been used to ensure that we fight against this pandemic from a global platform. Of course, South Africa and other countries of the South, such as India, are also engaging at a platform such as the World Trade Organization to make sure that issues of vaccine protectionism and intellectual property are addressed, so that developing countries are able to also develop their own capacities of developing vaccines and other interventions that are required. So I believe that, although there's a lot of vaccine nationalism that we have seen, especially with the more affluent countries amassing vaccines for themselves, there's a counteraction against that, where we are saying that we need each other. And if ever we don't solve the epidemic in one part of the world, it will come back to affect the other parts of the world that think that they are cushioned and isolated. The virus does not have boundaries. It moves freely as it wishes, even if you think you are going to be confining it. So the question around how long will it take for us to achieve herd immunity, and are we going to be able to mitigate against a third wave before we achieve herd immunity? I think the issue of herd immunity and being able to prevent a third wave are intertwined with how the virus behaves and the speed with which we are able to execute our inoculations to reach the target that we have set for ourselves. But looking at, and also how quickly are we able to continue with our non-pharmaceutical prevention efforts to make sure that the virus does not spread as fast as it has. But from experiences from other countries globally, it seems as if, you know, a third wave is inevitable, especially because we are seeing that, you know, the virus is adapting and readapting itself so that it can also survive. It's the nature of viruses. And we have a suspicion that before we achieve our herd immunity in this country, which is something that we think may happen over a period of 1 year, before that period arrives, it's inevitable that this virus may reinvent itself in another permutation and create another concern. What we need to do is to ensure that we do everything in our means, including wearing our masks, social distancing, washing our hands, and applying our public health containment measures to ensure that we reduce the likelihood of a new, more cleverer virus spreading as fast and causing devastations. And I'm sure our scientists here in this panel may explain this, that, you know, as the virus reinvents itself and increases its chances of coming back, it wants to live with the host that it has adopted. And therefore, we may find that with future infections, it might be less virulent and like what we are experiencing with the normal flu virus. But we don't know about this virus. It's a novel virus, and its behavior, it's quite unpredictable. And we hope that, you know, as we move on, we will start to understand the virus better and come up with other measures over and above the vaccination that will ensure that we mitigate against the fourth and fifth waves. But if you look at what is happening in other countries, you look at what has happened in some of the countries in Europe, in the Far East, and in the US itself, they have experienced a third wave or a resurgence for the third time. And we have to anticipate that as a country. Not sure if I had all the questions, but that's my input for now. Thanks.
No, thank you very much, Dr. Aquina Tulare. Unfortunately, we are now running out of time. There are a few other questions, but I'm going to say we have recorded this, so we have your questions. I know, Dr. Anban Pillay, you are still asking the question about the AstraZeneca vaccines. I heard the minister say this morning that there are some countries who want to buy the vaccine from us so that at least we don't lose the money, and you know, we will still get the other strain. I'm sure we will put that question to the department, and I'm sure Mags and others can come back to you on that. But at this point, I want to give Ela Gandhi an opportunity to say a few concluding words, and then I'm going to ask our moral compass, His Grace the Arch, to leave us with some words of thoughts.
Thank you so much, Vasu. I just want to say this was a really interesting, enlightening discussion that we really need to have. It's just the first, I think, in many other discussions like this, because there are still many doubts that people have and many questions that need to be answered as we go forward. But I think, thank you so much to His Grace for the beautiful words of encouragement, of spirituality, because right now that is what is required by all of us as we live with this virus and face the reactions to this virus. It's our spirituality that will carry us forward. So thank you for that, and thank you to all the scientists for their wonderful presentations and detailed explanations of what are the possibilities, how this works, the whole question of the need for taking the vaccination. I just want to say that, yeah, I will be the first one to be in the line when it comes. Thank you so much.
Thank you very much, Ela, and we wish you well. Please stay safe. We need you in this time. But thank you also to all of our panelists, well, starting, of course, with our co-host here, Professor Jinabai, always a bastion of strength for all of us. Dr. Aquina Tulare, I hope I got your name right. Thank you very much for coming from the department. I think it's always great that we hear from the department. And one of the things you've done very well as a department, and I think the presidency also, is to keep the public informed, almost on a weekly basis, sometimes on a daily basis. I think we appreciate that, so keep going with that. Dr. Priti Ramlochan, thank you very much. And good luck on the road with the rollout of the vaccines. Professor Kogie Naidoo, thank you. Yeah, those slides, I think it put it in perspective for us very clearly. So I think we're going to get you again to come and do another detailed presentation around that. And then, of course, we are sorry we missed Professor Chetty through ESCOM, but anyway, I'm sure we would have appreciated it. And Mags, thank you so much for giving us your experience and then telling us about the plan for the rollout. Everybody's wondering about the plan for the rollout. And I'm sure you're available if people have more questions about the rollout and what can happen. There was somebody who asked whether old people with the comorbidities can take the vaccine. So there are those questions that people have, and rightly so. So thank you all very much for joining us this evening with the Gandhi Development Trust and the Phoenix Settlement. And we hope that we will have another one of these soon to keep the public informed and engaged about the issue and to promote the fact that we should all take the vaccine. Now, Your Grace, if you can, in this trying time, we look up to people like you, and you give us leadership, and you've given us leadership for a long while now, but we really need your words of wisdom in this time, this challenging time. So I leave it up to you, and good evening to everybody. Have a wonderful night and stay safe. Arch, you have the floor.
Vasu, once again, thank you so much for creating this platform. And then Ella, it's always a pleasure to be with you and to share the message of hope in South Africa. I really want to underscore what everybody has said today. We don't have an option to lose hope. We don't have the luxury of giving up. Even when the coronavirus is trying to prove to the contrary. We cry, we mourn, we weep the loss of those that have died at this time, but it is up to us to make the resolve to live for ourselves, for the generations to come, and our children's children. Like Ella said, I will take a vaccine in order to encourage others to take the vaccine. Let us press forward. This is quite urgent. Let us move on issues of access. I appreciated the transparency tonight. From my faith perspective, there's a passage that says, the truth will set you free. I pray that our politicians, our scientists will take South Africans into their confidence and tell the truth as is. Dr. Tulare, I appreciated the fact that you said there may be the third wave, the fourth and the fifth wave. That helps us to change our behavior and know that we are in this for a long haul and that we need to do our best to realize hope in our time. So Vasu, we don't have an option to lose hope, but even this will come to pass. Thank you.
Thank you for those words, Your Grace, and good night to all of you, and good luck to all of our frontline healthcare workers. God bless you all. Take care.
Thank you. Thank you.
Thank you. Thank you very much, everyone.
Bye. Thank you. Bye.
Bye.
Thank you.
Night. Thank you.
Night. Thanks, everybody.
Thanks.
Sorry, Ila, you made it so late, but at least you got there.
Yeah.
Good
And
night.
with the connectivity.
Yeah.
Thanks so much. It was a lovely presentation. I've had many comments from different people saying that it was very informative.
No, it was
Yeah.
really informative. So,
And thanks,
great.
Varsha.
Have a good night and take a rest, Ila.
Take a rest.
Good night.
Thank
Good
you.
night. Bye.
Good night.
Bye, everybody. Thank you, Vasu. Thank you.
Bye.
Good night.
Bye.
Bye.